All right, looks like a lot of people are already logged in, so we're excited. We're glad that everyone has logged in and on time, especially considering what time it is, if you're on the East Coast or on the West Coast. So we're looking forward to a great talk. My name is Marcia Newby-Goodman, and I'm excited to kind of be the moderator for today. So we're going to kind of leave it pretty open and easygoing. So just in the middle of not in the middle, you can always kind of log on to the chat if you have any questions while we're kind of going through this webinar. And we'll try to incorporate any of those questions into like just the talk in itself. And then obviously at the end, we'll save some time for any additional questions where you can turn the video on. So I always like to see people instead of the names, it's like a conversation instead of me talking to a computer. It helps with that kind of tidbit. We can always ask questions and kind of go for there. But anyways, just to introduce myself, even though I'm the minute part of this webinar, my name is Marcia Newby-Goodman. Again, I work at Primary Care Specialist in Norfolk, Virginia. But today we have an amazing webinar planned for you all tonight. But just one thing before we also get too far along, this is just a reminder that the Sports Economics webinar series is available on the AMSSM YouTube channel. So you can always reference this webinar and other topics at your convenience, where you can keep hearing our lovely voices over and over again. But today we'll be learning about athletic trainers as physician extenders with Dr. Galbraith. Dr. Galbraith, aka Mike, because I have a hard time saying his name for some reason. He is an amazing primary care sports medicine specialist, currently working in private practice in Jacksonville, Texas. Yes, that is Texas, not Florida. He grew up in the cloudy but coffee-rich city of Seattle before moving to Utah for undergrad. He then moved to Arizona for medical school at Midwestern University, Arizona College of Osteopathic Medicine, before moving to Indiana for family medicine residency at Memorial Hospital, and he completed his sports medicine fellowship at the University of Notre Dame. Because of his love for the cold, or maybe because of the love for his wife, he moved to Canada for 11 years, where he was able to be a co-founder and medical director for Elite Sports Medicine, which is a multidisciplinary sports medicine clinic, i.e. a big-time clinic. After getting tired of the cold, Dr. Galbraith moved to the warmth of Texas right in the middle of the pandemic because he likes to live on the edge. Or it may have been due to his ADHD, because you can't stay in one place for too long. So while in Tyler, Texas, he was able to serve as the Associate Program Director of the Primary Care Sports Medicine Fellowship in UT Tyler. He is currently enjoying his job back in private practice at Family First Clinic, living the good life with his wife and 4 beautiful children. However, because it gets so hot in Texas, he still keeps his Canadian contacts as a sports medicine ultrasound instructor in Canada. So after that intro is all yours, Mike.
Man, pressure's on. Well, thank you so much, Marcia. Really appreciate the intro. And I just think these sports economics webinars are awesome. I just think they're great content. Having been in private practice, it's so good to have so many like the fellowship and residency based learning webinars, but we also have to learn how to function in the world and earn money. And I think that sports economics is great. So there's a great series. So I think that's a really good plug. If you guys don't mind, maybe what I'll do is I'm going to share my screen here and see if I can do this here for just a second. Great to see some familiar faces here on with us today. Yeah, I think as Marcia had mentioned too, if you guys have any questions, feel free to jot them down in the chat. We'll try to answer those either during or afterwards, or maybe even both, if you guys are on your best behavior. I'm gonna grab a couple things here. Okay, just rearranging my screen. So because I'm technologically challenged, Marcia, let me know if I'm running overtime. If you can't see my slides, you just keep me in check. So today we really want to talk about athletic trainers. And for the Canadians in the audience, little did you guys know, they're called athletic therapists in Canada. And so if you call them athletic trainer, or if you've heard that term athletic therapy, that's typically they're synonymous with athletic trainers. So we're going to talk about a few different objectives. Basically, we want to talk about what's the scope of practice for an AT. I'm going to use that abbreviation AT quite a bit throughout the talk as well. We're going to talk about what some of their roles as a physician extender in a sports medicine clinic, an outpatient ambulatory clinic, and then also what are some of the benefits you could have of having an athletic trainer in your office being your physician extender. Well, we always have to go over the conflicts of interest. I don't have any. Disclaimer, I will say when I was in Canada, I was in Canada for 11 years. For about 5 to 6 years, I was this co-owner of it was a relatively small multidisciplinary sports medicine clinic. And I had an athletic trainer for probably about 7 years of my time in Canada. And I loved it. It was amazing. It was so incredibly helpful with my efficiency and patient education. And I think just kind of general flow of clinic. So I'm going to share a bunch of anecdotes, but also share some evidence from some papers and research that talk about athletic trainers. My caveat kind of is billing can vary from state to state, and I don't claim to be a billing expert. I try to know my stuff, but obviously that can vary state to state, so just be aware. When we think of who's helping physicians in the clinic, typically, who is it? Well, probably most clinics will have an MA, a medical assistant, or in Canada, an MOA, a medical office assistant. Many clinics will also have different nurses from different levels of training. Here in Texas, they have to be different, so they call them LVNs. I don't know if anywhere else in the country they're called LVNs. I could be wrong. I think they're LPNs. Obviously, athletic trainers. There's many clinics, especially ortho specialty clinics, will have some of the mid-level providers like PAs and NPs as well. And this is just to give a little bit of background about athletic trainer education, just so some of you can be aware of their training. I think many people on this call have probably worked with athletic trainers fairly closely at one degree or another. So we know that athletic trainers, their real training is musculoskeletal medicine, right? That is their focus of their training. And most degrees now are actually master's degrees, kind of similar to like an NP and PA that are master's degree level. It's my understanding pretty much that bachelor degree programs have completely phased out, and there are some doctorate level AT programs as well. What I didn't know really for a long time is that actually ATs can complete a 1-year accredited residency. And so some of the authors of these papers that we talk about, they were instrumental in starting this residency program for athletic trainers. And it was just awesome. I was able to contact a bunch of these authors, and they were so willing to divulge all of their secrets and share all their information, their passion. They're so willing to work with physicians. Obviously, they see that win-win as well. So there's only going to be a small percent, and I don't know what that number is of athletic trainers that have gone on to do an accredited residency program, but that residency is kind of like residency we would think about in medicine, where they spend rotations with different specialists. And many of the athletic trainers and sports medicine docs that I've talked with that have had these athletic trainers that have gone through an accredited residency program, a lot of them say that these ATs function kind of like a PGY3 or 4 orthopedic resident, like pretty high level, right? There's different certifications. You might see abbreviations for athletic trainers. Sometimes it's a certified athletic trainer, so an ATC, or maybe they're a licensed athletic trainer, or they might have both just to confuse you. When we think of their scope of practice for an athletic trainer, traditionally, on the left side of the screen, we think, okay, well, they're going to work in high schools, right? They're going to be the high school athletic trainer. Maybe they work with a college, a university. They might work with a semi-professional or professional team. But one thing that's great now is there's just more and more opportunities available for athletic trainers to share their scope of practice in some of those maybe non-traditional roles. And if you look at a number of those bullet items, okay, there's sports medicine ortho offices. More athletic trainers are working almost synonymous with PTs. They're often hired now. They can be cross-trained to be cast techs as well. They're making more and more of a presence in the military with workers' compensation. Many, excuse me, large factories and large companies will hire them on site to help with injury prevention and treatment as well. And even athletic trainers can get trained in wound care and work in hospital settings with that. So, I mean, look, their scope of practice is really broadening more and more. So far, can you guys hear me okay? Volume's okay, Marcia?
Mm-hmm.
Perfect. Okay. So we're going to chat about advantages. What are some of these advantages of physician extender, and eventually how can we put them to work most efficiently in our clinic? And one of the big advantages of an athletic trainer compared to obviously an MA, they have so much more medical training than a medical assistant, but compared to an RN and many mid-level providers as well, think though their specialty training is musculoskeletal medicine. They may not have the same scope of practice with general medicine potentially as a PA or a nurse practitioner, but they have very strong MSK knowledge and skills. And with that, you can see the second bullet item, they're really trained to diagnose and acute injuries of any severity. So acute injuries, they can recognize that, help with recognition and treatment, subacute and even chronic injuries as well. And I find it's actually money, just ATs really understand return to play. And that is, and you don't think about that, but that mindset of how can we get this athlete or this patient back to their work, to their job, to their sport, to school, as quickly and safely as possible. That is a very unique kind of athletic trainer mentality. And then also sports medicine doc mentality. And it's no offense to some of the other providers like MAs, RNs, NPs, PAs. Generally speaking, they're not trained to think that way. So there's a very specific athlete mindset. So imagine this is your athlete here, right? Getting that athlete back to sport. She looks like she's going to rip the other girl's head off. Now, I will say a little caveat, that's my daughter. So in Canada, I covered rugby for 11 years, and their small town of Raymond, Alberta, population 4,000, they won like the state or provincial championship 11 years in a row against big schools, which is pretty amazing. But getting them back to sport, that's a different mindset, isn't it?
So I have a question.
Yes, please.
You definitely have, like, obviously the ATs have the clinical knowledge, but how do you actually apply that in clinic? How would that be beneficial to me in the outpatient setting?
Yeah, so let's chat about a little bit, how can we really put them to work in a clinic setting? What does that look like? Some of the nuts and the bolts. You can see that picture on the right. Well, sure, they maybe do taping, but that's typically something we think maybe in the training room. It sounds kind of weird. One big caveat, when I talk with a lot of athletic trainers and some administrators, the cop-out is it really depends on what are the goals of the system, what's the goals of the clinic, the hospital, what are the goals of the physician, and then you try to kind of match up your goals with this athletic trainer, and we'll go into some more detail. And also, you can imagine the skill set of your AT will kind of determine how you can best put them to work. The higher the level of training of an AT, the more you can delegate to them as well. There are a lot of different ways to use athletic trainers, which we'll talk about. I would say the basic way is many people use them like an MA plus, like just an MA on steroids, like we're going to do more. But if you just have them rooming patients and just doing vital signs, you're not going to reach the great potential of efficiency and reimbursement and job satisfaction as you would if you let that AT really practice at the top of their scope of practice. And that'll be one of our big take-home points is let them practice at the top of their scope of their practice. So we'll get into that here. So you can imagine here's an AT helping with a concussion assessment. Oh my goodness, can you imagine like in your clinic? How amazing is that? They can help really triage injuries so well. So I'd used, like I'd mentioned, an athletic therapist or athletic trainer in Canada for 7 years, and it was so helpful to have them triage injuries. I was, obviously it's a different system, but so many different referrals coming in, it was really difficult for me to efficiently triage some patients and when I should get some of them in when there's a 3-month wait at that time. My athletic trainer or therapist could quickly triage them and determine them acute, subacute, chronic, et cetera. And I find when you have an athletic trainer in the office, they're really trained to do a kind of a focused history and a focused physical, right? Let's talk about pertinent positives, pertinent negatives, and they can help so much with concussion assessment. They can do the initial concussion assessment for you. They can complete the SCAT form for you. That can save you so much time and help you with so much efficiency as well, especially if you're running behind a clinic. So what is unique, sometimes you'll see some healthcare systems, we even have a local healthcare system here in Tyler, Texas, that does a hybrid model where they use, I'm sorry, it should be an athletic trainer in clinic and in the community as well. So that AT might be in the clinic part-time. And then the other part-time, they're out working with a high school as well. So they have that hybrid model, both clinic and community as well. That's one that can be used too. A few other ways that you can use athletic trainers as physician extenders in your office. We have standard protocol right now. I just joined, honestly, this recent private practice 4 months ago, so we're still working on processes and policies. I have a young, relatively young LVN that's young to sports medicine, and helping her understand how to order appropriate imaging in advance. Again, ATs already understand that. They understand when we need to get imaging for the most part. They just have that advantage. ATs do an excellent job at typically prepping patients for the exam. So maybe this is a rhetorical question. You have a busy day in clinic. How often is it that, you run into a room and there's a patient for a shoulder, it's a female, and she's still wearing her full garb, and you're like, oh my goodness, I need to see her shoulder. I need to see her skin. All right, let's find a gown. Can you please put on a gown? All right, I'll be back in a minute. Or, oh, we're examining your knees. You have tight jeans on. Okay, we need to put you in shorts, right? We've gone over this many times, but again, it's that mindset. Athletic trainers understand that, and they really know how to prep patients for evaluation. But then you can also train them like a nurse to drop injections and to help you with procedures, help you with the ultrasound, and they can fill that void. There's a lot of evidence now about the increased efficiency of having an athletic trainer do a lot of documenting. So we're like, yes, train them in Epic or whatever EMR you use, and they have their dot phrases and their, but they can help tremendously with doing EMR work, and we'll get into that in just a minute. And as you see on the picture on the right, one of the great successes of having an athletic trainer in the office is they are experts in DME. You can say, hey, can we fit them with a brace or a splint? I don't know what to do. You help me. Or if you know what you want, right? Obviously, they can take that guidance and direction, but you can really trust that and delegate them to do bracing orthotics, fit them with crutches. And again, you can get them like certified in casting and splinting, or you can just teach them how to do some of those skills. And then maybe you get it started. And my athletic trainer, for example, when I was in Canada, I would start a cast and splint, and then she would finish it for me. And she got to that point, but it took some training, right? One of the greatest things about having athletic trainers is they love Notre Dame. And so this is a shout out to them. But one of the greatest things about athletic trainers is they're so helpful for patient education, right? Especially some of those bread and butter things that we see in the office. They can come in and say, hey, well, let's talk about your condition. Let's talk about a rotator cuff tear. Dr. Galbraith has just diagnosed you with a partial rotator cuff tear, and he's recommended a few different things, whether it's rehab, injections, etc. They can sit down and really go into detail and do more patient education about that condition. When that patient has lots of questions about pre-op or post-op recovery or PRP or a home exercise program, that AT can spend the time with them going over a home-based exercise program or really explaining the intricacies of PRP after I maybe give my brief spiel. So again, you're able to delegate. The physician can initiate patient education and then kind of pass that baton off to a skilled AT. So one other way you can use athletic trainers as physician extenders, they really can be a great liaison. I found this incredibly helpful communicating basically with your clinic and the athletic trainer at a different school. They really can help coordinate care. I know times in my career when I haven't had an athletic trainer in the office, and it's like I'm texting and phone tag with the other athletic trainer or maybe coaches, sometimes the athletic director. And it's so nice to have that athletic trainer be kind of that point person. But they can also be a point person too for referrals. Like maybe there's urgent care and ERs, and you can give them the athletic trainer's cell number or their direct line, and they can triage that injury as to, okay, oh, you've got an ACL, suspected ACL. Okay, yeah, that probably shouldn't wait 4 weeks to see me. Let's find an acute spot today or tomorrow. So they're great for a point of contact and liaison. We've talked about return to play. Again, under that patient education, they're so fantastic. As you've diagnosed a concussion and maybe that athletic trainer has helped you with initiating that screen and the scat, you go in, confirm some findings, and then you make the diagnosis and you can make some recommendations. Then again, you can pass the baton to that athletic trainer who can go in a little bit more detail about the return to play protocol. and maybe return to learn, returning to school, returning to work. And even just the little things like, oh, I need a note for gym class. I need a note for my teacher with concussion. Like, oh my goodness. All right, where's my blasted template and epic for this again? Like, how do I find this? And so these are things that the AT can do. Just another thing you can delegate, just help you be much more efficient. So Marcia, maybe we can go over an example?
Yeah, so I think so yes, if you can go exactly like a case example of how you use an athletic trainer, how they go through and how it actually benefits me and how it saves the time so I can see more patients more efficiently. That would be
Sure.
helpful.
Now, this example is specific to the mighty Raymond Comets from Alberta. So I'm just warning you. They're pretty intense. So here would be an example, just really simple, of how I could, or how I or you could use an athletic trainer in the office, help you be more efficient. So for example, let's say you have a 16-year-old football player come in and they have an acute knee injury. So the athletic trainer, who's very well trained, they room the patient, they triage them, and then they begin a focused history and physical. And as part of their history and physical, they know some of those signs and parts of the history, and they're worried about potential ACL injury. So then, while you're still with your other patient, that athletic trainer says, you know what, Dr. Galbraith is going to want an x-ray. Wonderful. They initiate the x-ray, and then the x-ray comes back. I step out of my room, the athletic trainer comes up, and then they can present that patient to me. Just like you would have like a resident, a fellow, or a medical student present. And again, it's usually focused H&P. They usually do a great job. And again, we'd be very impressed because they're doing such a great job. Then as a physician, I'd go back in and then I'd meet the patient, say, hey, thanks so much for coming in. You're an amazing football player. I hear you had a knee injury. I'm so sorry to hear that. And you can just quickly confirm some things in history. Again, you can really kind of focus in instead of, oh man, I have to do 20 minutes to confirm their medications again. And like, so you can really kind of cut to the chase and still be really kind and friendly and confirm some key parts of the physical. And then I would order the MRI. And then I can say, hey, great, I'm going to go over an initial plan with you and then pass the baton to my athletic trainer who's going to take over. Then I move on to my next patient. So here's that amazing athletic trainer showing so much care and love for my patient. And they're going to continue education about ACL tears. And they're going to talk about potential differential diagnosis. Thank goodness we have some DME in the office, so they're going to fit in with crutches. That athletic trainer can find a brace that can at least work. And because they're so skilled at Epic, they're going to write a note for gym class. And who knows, maybe their coach or the athletic director or a teacher. And then they're going to save you a little bit of time, and they're going to call the high school athletic trainer just to relay that information as well. And my favorite part is everyone is so happy, right? Thumbs up. Like
So that I mean sounds perfect in the ideal world if I had an athletic trainer that was able to be that efficient and got them trained well. But for example, if I'm in private practice or if I'm employed somewhere else, how do I actually justify the cost, even though in reality I need it? But you know, when you ask for stuff, they say, well, how much does it cost? Do I really need it? Can't you train somebody else for it? So how do you get around that?
yeah, apparently we actually have to run a business too as we're taking care of patients. So so yeah, we'll talk about that cost. And in full transparency, I don't have an athletic trainer right now because I can't justify the added cost. And as I'm starting my new practice in this new clinic, I'm getting my volume up. And as I get my volume up, then I think I'll be able to justify the added cost of an athletic trainer by showing how there's increased volume, increased reimbursement, increased throughput. So maybe we can chat about that. Very appropriate time to include this picture, I thought. So Donald Trump rolling in the money. I'll leave politics to the side, but so we're going to chat, how can athletic trainers increase your reimbursement in the office? Because there's great potential there. And first thing, we're actually going to talk about 4 things. Really, I bolded this in a really fancy yellow color because probably the #1 way that most doctors and athletic trainers think they can add the most value for reimbursement is volume. They can increase your volume, increase your productivity, increase your efficiency. That's it. We'll talk about a few other things, but we'll come back to volume and productivity. That's really the most important thing. You can bill for a code called therapeutic exercise, which we'll talk about as well. Some docs will upcode for a longer visit, we'll talk about that in a little further detail. And there are some specific athletic training or athletic therapy services you can bill directly for with their own CPT code. And we'll kind of briefly comment on that. So, so hats off here. There are some great studies out there. You can see this author, Forrest Pecha. So he's actually one of the founding fathers of athletic training residency programs. He's done a lot of research about using athletic trainers to improve efficiency as physician extenders. And he had this great paper in Journal of, I think it was Sports Health in 2015, and showed how ATs can really increase your volume and productivity in the clinic. And so, for example, his paper, what they did is they compared a sports medicine doc working with an MA for 6 months, and they looked basically at their productivity and their volume. And then they compared a sports medicine doc working with a athletic trainer then for the following 6 months, and they basically looked at their volume of productivity. Relatively small sample sizes, but they theorized that an AT can add about 2 to 3 more patients per day versus when you had an MA as your assistant. And that was pretty standard from other research that I saw. And I had a chance, in preparation for this, I spoke to numerous athletic trainers all over the country and numerous sports medicine docs that have used athletic trainers. And I'd say that's pretty consistent with what we see clinically. Most docs will see about a 20% bump in their productivity by having an athletic trainer as their physician extender compared to an MA. So this guy's rolling in the money here. So really what it comes down to is when you have an athletic trainer, it really allows you to see more patients, to be more efficient with your time. And it's not just that. A lot of times this research talks about throughput and downstream revenue. So for example, okay, yeah, you can see more patients, but that also means you're probably going to be doing more ultrasounds, diagnostic ultrasounds. You're probably going to be doing more casting, more splinting, more injections, more x-rays. And you can see that increased throughput and downstream revenue as well. That athletic trainer, again, with that ability to triage and increased efficiency, you can add more acute injuries, more same-day injuries, and people will love you because you have just increased accessibility, right? Patients can get in. Here's that same author, Forrest Pecha, in a different journal in 2017. Again, that's not really a picture of him, but, and in this article, they actually found, it was interesting, when they looked at the amount of time that an athletic trainer saved a physician, they looked at the amount of time they saved a physician when they're doing kind of their family medicine, general medicine versus their sports medicine. But even though their strength is an MSK, they found that ATs were still very efficient at their work, and they saved docs about 5.5 minutes per patient. Now, that doesn't sound like a lot, but let's say you're seeing 20 patients a day. If I do the math, that's a lot. So, and of course, their strength is going to be in MSK and orthopedic sports medicine. And this article found that they saved their physician about 7 minutes per patient for those orthopedic sports medicine patients, because they're just so efficient. They can focus, they can help that doc stay on task, and they can help with documenting, which is great. They found that physician documentation time reduced their documentation time by 37 minutes, and that was per day. And their conclusion I'll put through here is, they said ATs improved clinic efficiency by increasing their patient throughput, decreasing documentation time, while maintaining overall total time spent with the patient, which is cool. So it didn't actually sacrifice the patient's time with the provider. So their overall time was actually even a little bit longer between the athletic trainer and the physician. So the patients just really felt like they were getting a lot of great attention. It wasn't just, hey, the doc was with me for only 5 minutes.
So at least it sounds like I could see more patients and I don't necessarily have to add on extra time, documenting, and then increase revenue from basically having a more efficient process, it sounds like.
Yeah, definitely. Yes, ma'am. So I'll look on here. In 2014, this was a great article that talked again about athletic trainers finding ways to improve your productivity and volume in the clinic setting. And again, the standard, they typically will compare those athletic trainers to MAs, just because MAs tend to be the standard generally. And again, they found in this article similar findings: increased efficiency, patient throughput, productivity, while at the same time reducing documentation, and they still maintain that overall same time with patients. So similar findings. They found too, is interesting. Remember, if you're able to see 2 to 3 patients a day, which was the average, or about a 20% bump in your volume, one of their findings had said to, if you just add 3 patients a week, that increased your revenue by about $12,000 roughly. Now there's going to be variability, right? But you can see, wow, even just small improvements in your volume and productivity can have fairly significant improvements in revenue as well. So we don't have to extrapolate too much, but let's say if you're seeing 2 to 3 patients per day additional, you add that up, it's like, wow, that could be like, I don't know, 15 extra patients a week. That's pretty impressive. Well, all you really need to do is to see about 5 to 7 patients extra per week that would cover the added cost of an athletic trainer over the cost of an MA. Does that kind of make sense? When you look at how much more an athletic trainer you would have to pay them compared to an MA, you do have to see a few more patients, roughly 5 to 7 per week to cover that cost.
So basically to break even, because I'm paying more for this athletic trainer with a master's degree, essentially 5 to 7 more patients a week, but if they're increasing the efficiency, it should be easily met in theory.
That's exactly right. Yeah. And I think the caveat too is usually that's okay. Now you've got a pretty busy practice, right? It's going to be different if like you're starting a practice or you're only seeing 10 patients a day. That's a little different. But if you have a busy sports medicine practice, yeah, you're seeing 5 to 7 extra patients per week that will cover that added cost of the AT. Let's see here. So this author, Tim Nicolello, was also just an amazing resource, fantastic athletic trainer who had, out of Boise, Idaho, who had worked with a residency program, did a lot of publishing as well with Forrest Pecha. And he also commented on athletic training productivity. So this specific study in sports health, they really compared 2 primary care sports med docs. So again, I think a little bit of a side note is we really have relatively small sample sizes with the different studies that we have. So I think there's could be a great opportunity to collaborate with these athletic training organizations to really solidify this research with more clinics, greater sample sizes, more athletic trainers, docs. But I digress. So this specific one talks about 2 primary care sports med docs. So they call them physician A. So at the end of this study, what they found is physician A was able to increase their throughput or volume productivity by about 25%. Here in the American system, we have RVUs, or these relative kind of work value units. Excuse me. Per half day, they were able to increase their RVUs by 3.2 for this physician A. And then compared to that, physician B was a little bit different. Physician B was able to increase their throughput by about 21% and a bump in their RVUs by about 4.3. So one of those authors, Forrest Pecha, when I was communicating and chatting with him, he actually sent me an email, and I thought this was just pertinent to include. He says the physician's job is to diagnose and create a treatment plan, to treat the patient, not to treat the chart. The AT can take away the administrative burden for providers through documentation, et cetera. Once trust is built, the AT can also do the workup for the provider. Again, it's just finding ways to maximize their skill set and their scope of practice and being able to delegate things, even documented, so the physician can focus on treating the patient, not being bogged down by ordering the right DME, and then making phone calls, writing notes, et cetera, charting.
So I know like most of the time we're talking about just increasing productivity, but say if I want to be one of those physicians that have other ways of increasing the financial impact, like can we talk about those other things you had mentioned before about coding or upcoding?
Yeah, so we've spoken a lot about how we can increase productivity, volume, throughput. That's really the biggest one. We'll talk about those other 3. So let's say there's a specific, maybe number 2. If you wanted to bill for something called therapeutic exercise or therapeutic activity, there's actually CPT codes where you can bill for that. So if you look at these CPT codes, it's 97110 and then 97530. And you're supposed to have this direct kind of one-on-one contact with the patient, and you're going over the specific exercise program or therapeutic activity program to improve their strength, their function, their endurance, et cetera. Now, there are some caveats in order to bill this. So you have to be with them, or the athletic trainer has to be with them for a minimum of 8 minutes and you have to document that. And then this is actually billed in 15-minute increments as well. So let's just say you're only in there for the patient with 5 minutes, which would be fairly standard of 4 minutes, then you can't bill this code, right? So it has to be minimum 8 minutes to bill one of these codes. So I thought it was interesting, as I talked to more sports medicine docs, did more research, I was surprised that despite these codes being out there and available, there aren't many physicians that bill for them. There aren't many clinics or hospital systems that bill for them. And and I think the main reason was, one, it actually takes a lot of documenting time because you have to have very specific documentation about the time, the exercises, the volume, intensity for the specific exercise program. And what they're finding more and more is many of these hospital systems 3 years ago were getting reimbursed roughly $40 to $45 extra for that CPT code. But now, over the last year or two, they're getting zero. So it's been really inconsistent, and there's more and more insurance companies just not reimbursing for that. And so I think there's many docs and hospital systems saying, you know what, it's just not worth it now. So it's this last bullet is it says there's greater benefit for the AT to help the physicians see more patients, increase productivity, and use their time better spent doing some of these other things.
And with the cost, it might end up going to the patient's deductible. So they may have to end up paying more, then they'll get frustrated about paying more versus their copay. So that's something to consider too.
I think that's a good point. Like, and especially we know patients don't like surprise bills. Like, wait a minute, I didn't know I have another bill for $46. Where did this come from?
Yeah.
So there was this one athletic trainer. He's actually in kind of high level administration now. Wrote a paper, and he specifically said, like many academic orthopedic practices, and then he lists their institution, we choose not to bill for AT services. Instead, they measure, or their institution measures the success with patient throughput, increased efficiency, and effectiveness of a patient visit. And growing up in Seattle, obviously my all-time favorite baseball player, Ken Griffey Jr., has absolutely nothing to do with this slide, but I just had to find a way to include him. So thank you for humoring me. Just amazing swing. There you go. He probably needed an athletic trainer, right, throughout his career. So now, so we talked about you can bill for some of the therapeutic exercise, therapeutic activities. So did you know that ATs, you can actually bill some insurance companies for AT services directly? So these are totally different CPT codes. So for example, there's these 3 CPT codes, which I won't like read out loud, you'll fall asleep. But unfortunately, again, reimbursement from insurance companies is very inconsistent. Many do not pay, and as Marcia had mentioned, then unfortunately, a lot of patients are stuck with the bill. Little by little, we are seeing some insurance plans start to cover these services. So we'll have to see what that looks like maybe in the landscape in 5 years. There is potential that some of these services could be covered. So again, hey, athletic trainer, you're amazing. Can you go please do some patient education and a home exercise program for this patient for their knee arthritis or their rotator cuff tear? And they spend maybe 10 minutes with the patient. They can, submit this and get reimbursed $50 or something. In the ideal world. One thing that's actually really important to know, I didn't know this until I started doing more research. I didn't realize that athletic training services aren't recognized by Medicare. I had no idea. So there you go. So even if you tried to submit one of these CPT codes for your CMS patients, it will not be covered. So there's a term called upcoding. This is maybe the 3rd bullet point. How can they increase your reimbursement? So upcoding for time-based billing. In other words, okay, a physician might be able to bill for additional time with the patient. In other words, hey, I was going to bill a 99213 because I spent time with that patient. But now that I have an athletic trainer under my supervision that just spent 10 extra minutes doing a home exercise program and education, now I can bill a 99214 by using their services. So that's called upcoding for your time-based billing. Now, again, it has to be 8-minute increments or minimum of 8 minutes. I won't get into a lot of detail. There's something called incident to billing. So that's how they go through this kind of loophole. Physician has to be present in the office, but probably doesn't have to be present in the actual exam room to bill for this time-based billing. However, a lot of docs don't use this again because they really feel like it's a slippery slope and their fear of being audited. And I think there's just a lot of fear. Yeah, just to be real simple, I think the docs are afraid they're going to be audited and charged for malpractice. And so a lot of docs just don't want to do this. I think they're just really fearful of it. So this is not commonly used. And even the athletic trainers I talked to said it's not commonly used in the practices that they worked into.
So I know we don't have too much. I want to make sure we have enough time saved at the end for questions. But like all this is really helpful information. But at the end of the day, we always want to know about the patient experience, about how they respond to athletic trainers, and how athletic trainers do they get excited for positions like this. How has there been any feedback regarding their satisfaction?
Patients should be excited about having athletic trainers. Yeah, so we have some good research and evidence for both patient satisfaction and also physician satisfaction and quality of life working with athletic trainers. So we'll talk a little bit about that. All right, shout out to some of my Canadian friends here. The good old Western Hockey League, Lethbridge Hurricanes. This is Stuart Skinner. Stuart was an amazing goalie, worked with him many times, and is now the starting goalie for the Edmonton Oilers. There you go. So I had to throw in again a little Canadian hockey here. So again, that name, Forrest Pecha and Tim Nicolello, two great athletic trainers again, they did a joint study again that talked about patient satisfaction using athletic trainers. And basically, yep, it's great. There you go. It's great satisfaction. So they actually found, if you break it down to numbers, it says the mean overall satisfaction score is 9.1 out of 10. That's pretty good. So most of the time, patients were really satisfied because they felt like they were really getting a great patient care experience. They had a confident athletic trainer that knew that we were talking about. And again, there's some systems and clinics that are used to, oh, the average physician is with me face-to-face for 7 minutes, right? So, well, now they might have that 7 minute or maybe 5 minutes with the doctor, but now they have an additional 10 minutes with an athletic trainer. So they love that education component, and you're kind of like you're like holding their hand. They love that. And then another study also looked at what about physician satisfaction. This specific study looked at athletic trainers that were residency trained. And again, it found great. Physicians loved having athletic trainers. Again, their satisfaction score is 9.0. QOL is their quality of life was 8.5. So again, you can kind of say, hey, this looks like a win-win, right? Shout out to Marty Polachuk. So he was my athletic trainer with the Western Hockey League, Lethbridge Hurricanes for about, probably about 6 years or so. So I had to Facebook stalk him to get this picture of him and his son at a practice game. So what about practice rights? Do they vary from state to state? Short answer is yes. It can be really variable. So maybe I'll back up for a second. Here in Texas, I'm going to show you the extremes. Here in Texas, athletic trainers can do a lot. It's almost like whatever a physician wants to delegate to an athletic trainer, they can do. If you want to help me in the operating room, scrub on in. Hey, do you mind sewing up this patient for me, putting on a cast? As long as you can delegate and you feel comfortable with athletic trainer, you can give them a lot of responsibilities. They have a huge scope of practice. Then you compare that to California, where athletic trainers are not considered licensed or certified, right? Completely different. There's a great organization we'll bring up later. So it's called the ATPPS. So it's the Athletic Trainers in Physician Practice Society. Fantastic organization, but as the name states, they are a specific organization of athletic trainers, and their focus is how can we better practice in physician clinics as physician extenders? That's their goal. And that's actually how I made some of these connections with some of these athletic trainers. They are ones that really spearhead a lot of this research about physician extenders. Also, just know that reimbursement will vary from state to state. So this is my son now, who is like a few inches taller than me, has a lot more hair than me. He's 15. This is him when he was like 7. So everyone wants to know, okay, let's get to the nuts and bolts about salary. How much does it cost? It really does vary. On so many different regions, about 50 to 60K a year is pretty common for an AT. And then you can maybe back up to 80K a year for someone that's really well experienced, or maybe they're residency trained. But think of the factors. Okay, factors on their pay. It's going to depend on their experience, their education, what certifications and added certifications do they have. Of course, the region of the country that they practice in, and also maybe urban versus rural, et cetera. And you compare that maybe to an MA salary that's like 30 grand a year, 35 grand a year. So definitely AT is more expensive.
Yeah, but at least the turnover, I would presume, would be less than trying to find the expense of hiring, firing, not firing, hopefully. Like MAs, like that turnover is a lot higher, and we expect hopefully it's a lot less with the ATs when you train them to help justify it.
Yeah, and I think that's a really key point. The average MA program is anywhere from 6 to 12 months. And so you think about that's a kid typically out of high school. It's an entry-level position in healthcare. And there's a lot of turnover, there's either they use that as a stepping stone to maybe get their LPN or to go to phlebotomy or a different field versus AT now. Okay, I'm going to be, master's level AT. That's usually where they're going to stay. They're typically a little older, a little more mature, generally speaking. No offense to my daughter that just started her MA job this week, but let's wish her the best, right? So
All
some
right,
people,
Mike. Sorry,
yeah.
let's try to we're getting a little short on time, so not to rush you, but I'm rushing you a smidge.
Great. All right. So real quick, people say, well, I have no idea where to find athletic trainer that can work with me in the clinic. Well, here you go. There's an option. Network. So we all know athletic trainers in our community. There's a ton that are really burnt out with weekends and weeknights, and they're looking for a stable 8 to 5 job. If they aren't, they probably know someone. That one website, the ATPPS, is a great website. They have a website job board. You can jump online and look. There's also the National Athletic Trainers Association, but you can also look at like Indeed and ZipRecruiter, et cetera. Shout out to my friend Manti Te'o. There we go. Did not have a stellar season in the NFL, unfortunately, because of injuries. But so if you want to find good, I think we just mentioned the market is actually ripe for finding an athletic trainer that really wants more predictable work hours. Now, remember, you still have to train them, but if you have someone that's a master's level or a residency level, there's much less training required versus if you're starting with a new MA or a new RN, et cetera. And okay, this is maybe an important slide, and I think we're just about to wrap up here too, Marcia. I think a lot of people say, okay, that sounds phenomenal, but how in the world can I convince my administration to hire an athletic trainer to work with me? How can I justify that cost, right? And so I've had the pleasure of talking to a lot of administrators the last few years, especially my previous position with our sports medicine fellowship. And you really have to think like an administrator, right? What do administrators care about? Money, right? And it sounds mean, it's not meant to be crass, but it's a business and all they care about is money. So you have to find a way to speak their language and frame it as a financial decision. And it sounds goofy, but I spent a long time barking up the wrong tree for a long time trying to get things done at my last administration, realizing that person actually did not have that power. Make sure you're talking to the right person who actually can have control over decisions. And then I think you really need to help them understand, okay, not only can athletic trainer do everything an MA can, but help them understand administration. Hey, this will help with our reimbursement. This helps with revenue, productivity, and volume. You start using those words and their eyes start getting bitter. They really don't, it sounds to me, they really don't care about like quality of life and patient satisfaction, despite what they say. They care about the money, right? Again, we can tell them we're treating more patients in the same time period. We're improving that throughput. Now, there are many people that haven't done this, but you really should put together like a business proposal that's beyond this talk. But you need to put together a proposal that includes money, that includes data, and you have to show administration that here is what we can make, here's what we can save, and you can use a bunch of the data we've included in this talk here. So for example, and then you need to pray a lot and pray that they'll listen, right? This is what it'll look like. Many times you're sitting in front of a board of administrators and you have a sweet PowerPoint and like you're rocking a suit and you're looking professional and you are prepared to talk money. You're not prepared to talk about patient care experience. It's money and you have to know your data. All right, now I'm wrapping up. So some people talk about pearls. I've always been a nuggets guy. So here are my final nuggets of using an athletic trainer as a physician extender in the office. So as our US healthcare system evolves, I really think athletic trainers can improve our patient care experience. They can really improve our service we provide our patients, which we love. At the same time, we're doing it more efficiently, and we can actually reduce the overall cost for our patients. And I think ATs like fit that perfect mold to be physician extenders in the clinic. It is fantastic how that can improve your patient experience, productivity, and throughput. We talked about reimbursement, but also remember ATs can really improve your access as you're improving your efficiency and their ability to triage. Get those patients in quickly, and that's patient satisfaction too. I think to really make this successful in your clinic, you really have to train ATs and let them practice at the top of their scope of practice. Don't just use them like an MA. Delegate, 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 but you'll probably have to train some. And then I think as we have that added reimbursement from throughput productivity, that should be able to justify the higher salary of hiring an AT. References here, I have a number of references. Shout out and special thanks to a number of the athletic trainers. I did not list all the athletic trainers and sports medicine docs, but I wanted to do a wide sampling all across the country of some colleagues, et cetera. So special thanks to them. I'm going to stop sharing and stop talking. Let's see. Can you see me now, Marcia?
Yes, we can see you. It was a
I'm sorry.
great talk, and we really appreciate it. But before we go to questions, I did want to clarify this one question that was put in the chat from Terry. So I think just to kind of, because I know you came on late, just to clarify, we weren't saying a lot of the clinics were necessarily upcoding. He was actually saying very few were doing that because of the concern of like a slippery slope in the incident to billing, and then the CMS doesn't recognize athletic trainers as providers. But it was just more of increasing productivity and increasing the number of patients being seen in a week. And I think, Mike, could you quote like saying like we saying like 2 to 3 patients a week ended up 12,000 in revenue increase, or what was that data?
Yeah, so again, about 5 to 7 patients per week would cover the added cost of an AT. And if you're seeing about 2 to 3 patients per day, that equivalents to $12,000 per year.
Okay. And so before we go to quick questions, just so we don't run out of time and before people check out, I did want to say, just to remind everyone listening that the next sports economics webinar is scheduled for June, and we'll be learning about direct primary care and sports medicine. It'll be with Dr. Dan Clearfield and Dr. Mary Tierney. So I just want to put that plug out there, but please use the chat to put any questions, or even put your face up on the screen so we can see your face and we can ask questions that way. So let me see if anything else is popping up, if someone wants to ask a question real quick. But as I'm looking at that, hey, Mike, do you have the average timeline for how long it took for people to train ATs to kind of to work at the top of their scope?
You know, a lot of it really depends. So some of the older ATs have bachelor's level degrees. Some of them can be really well trained and have a lot of experience, but maybe it's different when you're in a clinic setting, so that might take longer. So for example, the athletic therapist I had in Canada, it took her about 1 to 2 years, and then she was quite independent and had fantastic skills. She was great. She would always pimp my residents. It was amazing. In regards to, you know, more athletic trainers are master's level trained now. And so I think they're obviously they have a greater wealth of knowledge. And those that are residency based, they just hit the ground running. They're used to that outpatient clinic setting with very little training. Specifically, it's just more to like, what are the nuances of your own clinic?
Okay, great. So we're getting a lot of thank yous, but
That's great.
come on, guys, more questions.
Well, I got a question for Mike because I don't use NPs or PAs up here. I think a lot of healthcare systems are going to ask about, well, why would we hire an AT when we can put a PA or an NP to work in our sort of primary care wing? Have you got thoughts about that?
Yeah, and so pay can be different. Typically, an NP and a PA will cost more. Oftentimes $80,000 to $120,000, so they typically will cost more. In that role, if it's just clinic-based, an AT, especially an outpatient sports medicine clinic, an AT can do pretty much in everything an NP, PA would do. Now, that's not fully true, but for the most part, if they're an orthopedic surgical practice, they can go into the OR, they can typically assist more, they can see a lot of post-op follow-ups. ATs can do a lot of that too, but ATs can't prescribe. So that's one of the main limitations is ATs can't prescribe.
And one final thing, but before you get to Ellie's question, is there a way you can share those codes and stuff? Because if viewers want to petition their higher ups, they probably need access to your presentation.
Happy to, yes. Yeah, happy to share that. Marcia, do you know the best way for me to do that? I mean, I could send out a PDF of my PowerPoint that includes those, or I could, or if there's any other recommended way, I'm happy to do that too.
We may have to follow up. I just know we posted on the YouTube channel, so you can always just, you know, it'll be up by tomorrow morning, and so you can just get there and just re-record it or just take a screenshot of the codes to save it. That'll probably be the most efficient and quickest way. Okay, real quick, I did want to get to this one good point of a question. It's like, so what are the limitations of ATs in sports medicine clinics? Since we did talk a lot about the advantages, anything to anticipate in terms of roadblocks or disadvantages?
You know, that's a great question. And honestly, when I chat with a number of sports medicine docs and athletic trainers, really the big thing that came back is some of you just have to train. That was probably the biggest thing. And then they can't prescribe. Those are probably the biggest roadblocks. And also one of the other biggest roadblocks is physicians and healthcare systems not understanding their scope of practice and letting them practice to the top of their practice. And remember, it can vary a little bit from state to state too.
Hey, Mike, quick question for you. Following up on that, blood draw for PRP and then drying up meds for injections. Is that a kind of across the board? If you feel comfortable that they can do it, you can let them do that?
There is potential it can vary from state to state, but most clinics and most states will allow them to drop procedures and help drop PRP as well. Yeah,
Okay.
so there are a lot of places that use ATs that actually will even let them do the PRP. So we'll train them in PRP, but usually they'll do blood draw, they'll do the processing, get the patient all prepped and draped. And then the physician walks in like the knight in shining armor, come in, does the procedure. Then the AT finishes up with patient education, post-PRP instructions, rehab protocols, etc. Great question.
Yeah, but we have another question. It's like, how do you kind of balance utilizing ATs to rooms, patients versus helping with procedures?
Yeah, so this honestly is a little bit of a struggle. Maybe it goes back to some of the disadvantages that I didn't include. If your only assistant that works with you is an athletic trainer, you can't totally abuse them to this full capacity, right? But many of the docs that I talked with that work in busy sports medicine clinics, they often have an MA plus an athletic trainer. So the MA is often doing some of the simple basic phone calls, ordering ultrasounds, MRIs, rooming some simple patients, and then the AT is doing a lot of the initial focused H&P. I think that's one of the limitations, though, is if your only physician extender is just the AT, they obviously can't spend as much time doing some of those other things because they still have to get the next patient as well.
The next one, if hiring an AT, which is now supervised by you as a physician, would your employer now need to increase like malpractice coverage, or do they operate under their own coverage plan or under your license? Or
boy, I honestly don't know. I don't know the answer to that. I'm happy to look into that. I can even reach out to some of the other athletic trainers that have worked in this setting a lot with the residency program, and happy to follow up on that.
And probably a short, in my 2 cents, a quick answer. You can always reach out to like the malpractice company that you're with, and sometimes they may have insight in it as well, because it could vary by state.
Sure, I bet it does. I bet there's a lot of factors.
Hey, Mike, I'm in California, and I know Elliot's in California. So we are the one state out of 50 that has no licensing. We have credentialed, but no licensing for our ATs. Do you know of a good place where we can go to access, I guess, a bread and butter scope of practice? Try and figure out how we can present this to admin and HR.
Like bread and butter scope of practice of athletic trainers in general?
Yes.
You know, probably that one website that I mentioned, the ATTPS, is a fantastic website, and it's geared towards even a lot of lay people as well, learning about how athletic trainers bring value to physicians in clinic offices. And I mentioned a couple of those names, Forrest Pecha and Tim Nicolello. They are happy and more than happy to chat with physicians on the phone or by email, and I can share that information. What I'll do is, if that's okay, I'll put in can I put my cell in here? Am I allowed to do that, Marcia?
Well, yeah, but it's going to
Are
be
you guys-
posted up on YouTube, so maybe we should do it after.
Ooh, yeah. Frank will be calling me all night. So,
So
um,
maybe, um,
I'll give them your cell number.
no, how about this? I mean, the group chat. So maybe I'll put my email in the chat,
Mhm.
and then you can send it to me, and then I can forward it to you, Mike.
That'd be
That
great.
might be the
Because then I'm happy to forward some of that contact information, not only just for myself, but some of these other athletic trainers that would be more than happy to chat.
okay, perfect. Well, all right. Not that we're not having great conversation, but I would love to keep this going. But I'm on the East Coast and it's late, and I got 3 kids. But we appreciate everybody joining us, and I hopefully answered a lot of questions, or at least get you on the right path. But Mike is definitely available for, well, I'm gonna assume he's more available for more questions or anything afterwards and more specific, because he did end up finding a lot of good information kind of preparing for this. It was definitely helpful from myself as well. So we appreciate everybody, and you guys have a good night. But I will go ahead and put my email in the chat, so we can help forward any information to anybody needs it. Thank you so much. Thank you, Mike.
Thank you.